Ladies and gentlemen, thank you for inviting me. My name is Duen-Pang. Our research topic is differentiation of the Infarct from ischemic penumbra within the first 4.5 hours using diffusion tensor imaging-derived matrix, a red model. There are two major types of stroke. One is ischemic stroke, and the other is hemorrhagic stroke. In Taiwan, ischemic stroke constitutes approximately 80% of overall strokes. In 1995, the NINDS study group reported that treatment with intravenous RTPA within 3 hours of the onset can effectively improve the patient's neurological function and resulting a favorable outcome at 3 months. The current approach to patient selection for stroke thrombolysis is based on the time from stroke onset. However, for a subgroup of patients with stroke, for example, wake-up stroke, the exact time of onset is uncertain and they will be excluded from RTPA treatment. Fortunately, technical advances in neuroimaging offer new promise to clinicians. Advanced neuroimaging can provide important information on the state of the brain parenchyma and of the neurovasculature, which may guide treatment outside the current time windows. In recent years, there have been a number of clinical trials investigating the therapeutic time window beyond 3 hours of the onset. The selection of patients for thrombolysis may be made by considering individual salvageable tissue rather than relying solely on the onset time as a determinant of selection. Salvageable tissue, that is to say penumbra, can be defined by perfusion-diffusion mismatch concept. We can use DTI and PTI to delineate Infarct and perfusion deficit respectively and further co-register to define penumbra. A stroke patient with mismatch ratio above 1.2 or minimum mismatch volume of 10 ml is most likely to benefit from reperfusion and to have good outcome. Taken together, the ideal candidate for thrombolysis is knowing the onset of acute stroke and better within 4.5 hours, as well as a presence of substantial ischemic penumbra. Imaging technique of MRI, such as diffusion tensor imaging, has emerged as a promising tool to study acute stroke. DTI has shown to be capable of delineating in the microstructure changes of brain due to ischemic strokes-induced damage, commonly expressed as the fraction anisotropy (FA). We hypothesize that the evolution of DTI matrix changes may differ in IP and IC regions due to different stages of axonal and myelin damages as a result of a different extent of perfusion deficit. Accordingly, could DTI matrix delineate IP and IC? We further hypothesize that the DTI matrix alternations can be used to predict the first 6.5 hour onset time of stroke. To verify hypothesis, we established permanent middle cerebral artery occlusion model in rat to observe the temporal evolution of DTI matrix changes in IC and IP with 6.5 hours, and to delineate the IC and IP using DTI matrix by comparing PWD as standard. This experimental procedure was approved by the local Institute of Animal Care and the Utilization Committee. At males, brachythoracic rates was prepared for permanent MCA occlusion using the intraluminal suture. Imaging acquisition was performed at 70 Tesla, MRI scanner, T2 weighting, DWI, DTI, and the dynamic sensibility contrast perfusion imaging was performed at time points, starting from half hour after MCAO, then repeated every hour until 6.5 hours, with a final 24 hours imaging performed for the assessment of the final infrared volume. Data analysis includes calculation of functional maps, delineate IP and IC within PWD-DWI mismatch concept, tissue segmentation, linear registration use FSL software. Abnormal FEC was defined using a reduction of 30% of the contralateral hemisphere with the exclusion of the ventricles. A lower CBF threshold of 46% reduction was used in this study to identify CBF deficit. Infarct and the CBF deficit was then mapped onto FA map. Due to the non-variability in normal FA values with gray and white matters, in this study, we applied an atlas-based tissue classification method during imaging processing to identify the tissue types with each imaging vessel for each ray model to observe the variable tissue responses to the ischemic injury. For tissue segmentation, FA template and imaging atlas were used. A color represents a brain structure. This is the result of spatial maps of identified cortical, subcortical gray matter, and white matter for a rate. Because the FA is a relative scalar value defined by the ratio of pure and isotropy Q and the diffusion magnitude L, accordingly, in this study, we measured the parameters Q and L separately for a more complete picture of diffusion changes in acute stroke. Finally, the relative DTI matrix as compared to the contralateral homologous tissue was calculated as follows equation, where X indicates the measured FA, L, or Q. Results. Figures A and B illustrates the L and the Q maps, demonstrating a consistent hypo-intensity change in the ischemic areas over all time points. The FA maps exhibit an initial elevation of FA value at half hour in the ischemic region and a later reduction at 6.5 hours. This is the temporal evolutions of RL values in tissue subtypes. The reduction of RL value in IP and IC was approximately 10% and 30% half hour after MCAO, and the evolutions of RL value were stagnant and similar for all tissue subtypes. Significant difference in RL values were found between IP and IC and between IP and NT at each imaging time point for all tissue subtypes. The acute value in IC exhibited a monotonic decrease from a reduction of 28% at half hour to 50% at 6.5 hours in both cortical and subcortical gray matter. In contrast to the similar evolutions of RL value in gray matter and white matter, there is a larger reduction of RQ in white matter than in gray matter within the first 2.5 hours. The FA evolution depends on the changes of RL and RQ values. Accordingly, the relatively small reduction of RQ as compared to a large reduction of RL resulted in a 20% increase of FA in the cortical and subcortical gray matter IC regions at half hours. At 6.5 hours, the reduction of the RQ value became greater than the reduction of RL, leading to a marked decrease in FA in the same region. On the other hand, the evolution of FA in white matter IC was relatively stable due to the similar decay profiles of RL and RQ. The ROC curves of discriminating IP from IC and NT are shown. The area under curve of IP versus IC is larger than that of IP versus NT. The overall performance of tissue-specific RL thresholds is listed in this table, which show excellent discrimination of IP from IP by RL in all tissue subtypes. The discrimination performance between IP and NT is good in the subcortical gray and the cortical regions, with an average accuracy of 83% and 79% respectively, and moderate in the white matter region with accuracy at 68%. The threshold for discriminating IP from IC is about 29%. The threshold for discriminating IP from NT is about 11%. The maps of RL defined IC and IP as compared with the corresponding perfusion diffusion defined IC and IP of a rate suggested that the RL defined maps can segment the ischemic regions into IP and IC. The T2 weight image at 24 hours showed complete infarct of the expiratory MCA territory. A nonlinear regression analysis was further applied to estimate the relationship between the acute values and the time after stroke. The past time after stroke onset can be assessed by this equation. This exponential decay of the acute value over time suggested that acute value in cortical IC can be a potential surrogate marker to determine the stroke onset time at the hyperacute stage. For instance, an acute value reduction smaller than about 44% predicts an acute stroke onset less than 4.5 hours. In conclusion, our preliminary results suggest that a single DTI could provide a quick and reliable measure to distinguish IP from IC based on the L values, and as the main stroke age using the acute values. Thanks for your attention.